Good morning. Thank you for joining us for this fifth of our seminars in collaboration in home and community-based services, infection and prevention control. We are very pleased today to be um, joined by our two presenters, Melanie Rhonda and Sarah Butterfield. And I'll turn this over in a few moments, but just want to welcome you on behalf of Al Cardillo, our president and CEO. I'm Peter Chernak, executive vice president of the Home Care Association of New York State. And we're thrilled and even a little sad that we're coming to the end of this five-part series that has just really been excellent all the way through. And I'm grateful to our colleagues from IPRO who have led each of the sessions so ably. And I'm also, of course, grateful to New York City Department of Health and Mental Hygiene, and in particular for the support that we've received from our colleagues at the department, and from Fidel Monroe in particular, who is the senior program manager for long-term care at the Bureau of Healthcare and Community Resources, Office of Emergency Preparedness and Response. Um, we're partnering with IPRO on this project with true gratitude, and we're also thrilled that the products of these webinars will be available on an ongoing rolling forward basis through our website. And that's available to everyone who wants to view these webinars and take advantage of the great material that's being presented. That said, I'm going to turn this over to my two colleagues from IPRO, Melanie Rhonda, who is the Senior Healthcare Quality and Infection Prevention Leader with more than 2 decades of experience across acute and long-term care settings. She's currently serving as the Senior Director of Healthcare Quality Improvement and Infection Preventionist at IPRO. Melanie is recognized for her expertise in infection prevention, regulatory readiness, and process improvement, and is a frequent speaker nationally, and has co-authored mandatory infection control education that meets New York State requirements, and is just deeply committed to advancing patient safety and quality outcomes. Sarah Butterfield is with us this morning, and Sarah serves as the Assistant Vice President of Healthcare Quality Improvement for IPRO, and the health system lead and engagement lead for the Northeast Centers for Medicare and Medicaid Services in Region 1. Sarah's experience incorporates cross-cutting healthcare quality improvement, clinical care delivery, case management, utilization review, and project management, as well as administrative oversight of several federal and state performance improvement initiatives. Sarah has coordinated collaborations across the healthcare sector in her decades of experience since joining IPRO, and has worked with community-based organizations on cross-setting multidisciplinary level support to improve healthcare outcomes, coordination of care, and population health. So I'm sorry for that lengthy introduction, but these are just two formidable presenters, and thank you for joining us this morning. Mel?
Thank you. Well, we're been here with you for 5 topics. We're very excited to be here again, and we're glad to kind of be wrapping this up. So today we're going to talk about identifying the importance of cross-continuum communication, care coordination, collaboration with the HCBS population, discuss opportunities to assess current agency protocols for infection prevention and control, reviews best practice for agency adoption to support timely assessment, communication, and coordination of an emerging infectious disease, novel and infectious. So let's get talking about it. So before we go any further, I thought it was important to talk a little bit about the chain of infection. We have gone over this, but the reason why it matters so much, if we are in an outbreak, we all need to understand, how does infection spread? So the chain of infection, you have a microorganism, a bacteria, a virus, a fungus, a parasite. It could be a variety of different things and something emerging. We need to have a reservoir or a source, so a habitat for organisms to grow, which could be a human, an animal. So human, when we think of COVID, um, and an animal, that's avian influenza. That's one of the topics we've been talking about during the series. So air, food, soil. There's, you definitely hear of foodborne illnesses and issues that people get sick from soil, water, Legionella. You might hear of Legionella for the water, and then equipment. So these are all different ways that can harbor bacteria, the microorganism. So you need a portal of exit. So secretions, saliva, excretions, urine, feces. So that portal of exit. So is it coming from the mouth, the nose, the body in some way? And then mode of transportation. So we talk a lot about PPE, so personal protective equipment, gowns, gloves, masks. Well, that's because of the mode of transport. So it could be contact, droplet, airborne, vector, fomites. These are different ways that bacteria can move, and it's the chain of command. So we got your bacteria, you have a place that it's living, you have a way it's getting out of the place that it's living, and the mode, contact, droplet, airborne. Port of entry. So how is it getting into the person, the human? Mucosal lining, opening of a wound, oral, respiratory tract, urinary tract. And we have been talking a lot about respiratory virus. So thinking about that droplet airborne, it's coming out of someone and then it's coming into someone, that port of entry in the respiratory, the mucosal lining, the respiratory tract. And then the susceptible host. So is somebody very young, elderly, those with chronic disease or malnourished, immunocompromised, and then sometimes it's just the right set of circumstances, right? A very healthy person could still get sick. We saw that with COVID. We definitely saw that with COVID. And I also included a link with the chain of infection components that could be helpful if you're training your staff in some way. So thinking about that, I want you to keep in mind that chain of infection when we're talking for the rest of today. So we're going to do a quick review. We started this program really talking about some respiratory issues, so COVID, RSV, influenza, and I really love this slide because it tells you how these respiratory illnesses are transmitted, and then the symptoms of them, and time from exposure to infection. The challenge with that time from exposure to infection is that sometimes with these viruses, you could be sick and spreading. You could be spreading. It's called asymptomatic spread. So you could be spreading the virus before you know you're ill. So that is one of our challenges. And that's what we face when we're dealing with an outbreak or a new emerging disease. So I'm setting this up, and now I'm going to turn it over to Sarah to start talking about some of the other areas we want to talk about in the community.
Thanks so much, Melanie. And I just invited the folks that are on attending to enter their information, where they're from, in the chat, as well as any questions and their feedback, because we'd love to incorporate them into this discussion as well. This is one of my favorite topic areas: care transitions, communication and coordination of care, and collaboration across the healthcare continuum, and especially in this important topic area of infection prevention and control. So the why this is important. Those of you on the line are home and community-based service agencies. You are providing essential care to those multi-comorbid older adults. They are medically fragile, they can be immunocompromised, and living with many different chronic conditions, taking many different medications. So they're at risk for infection. and we want to prevent that from happening. So we're going to talk about how, because you're not in a controlled clinical environment, how can we look at infection prevention and communication and collaboration across the community settings, and have staff compliance along with that. So looking at agency-wide systems that must be in place to support, we'll start out looking at early identification of infection risks when patients come on to care, and throughout their time with you. Also, timely communication of any change in status or any observations or assessments. A coordinated response across the different settings that are involved in the care management of that patient or client or resident. And also staff education so that they're aware of what needs to be done in the lines of communication and support. And again, why this is important. And then that collaboration with patients, families, and caregivers, healthcare providers, and the public health partners at large will bring back a little bit of what Melanie talked about during our last session, which was looking and providing education to patients, families, and caregivers. And we'll move to the next slide. So looking at the federal requirements, and again, why is this necessary? The infection control program, maintaining one within your organization that's focused on both prevention and control of infections and also communicable diseases, is mandatory. It needs to include the accepted standards of practice, standard precautions that staff have to take within the home care setting, also surveillance, identification, investigation, and then that ever most important education of staff, patients, and caregivers. The reinforcement is imperative for coordinated agency-wide approaches rather than isolated activities that are performed within the organization. So it is important from top on down that staff understand what their role is for an agency-wide approach and infection prevention and infection control. Next slide. Part of this is looking at those building of community partnerships, and this is where the care transitions piece of me comes in. Being able to work across healthcare boundaries or healthcare silos, which we sometimes refer to them, and to bring in all of the care partners that are caring for that particular patient, to improve their health outcomes, and the right thing to do. So you all are part of the same community that you're working within, and you serve the same population of patients. You have the circle of healthcare, if you will, all involved in the care management and the outcomes that happen with the patients that you serve. So you have the same culture and challenges that one another are experiencing. You have the ability to share your protocols, your tools, resources, and expertise. And also, the opportunities exist to align your efforts, reduce duplication, and improve that overall health outcomes. But it's imperative that you know who your healthcare partners are and who those different settings are important. And they should be also a part of that protocol that's in place and the approaches that your staff understand that need to be put into place when an infection or outbreak occurs. Next slide. Melanie, can you talk a little bit about the state and local health department involvement in, because you have a lot of experience with that.
Yes. Well, first off, I recommend that if you don't already have a working relationship with your local health department and your state department of health, that is a takeaway from today. You need to get connected, that you know who you would call if you're seeing something that's abnormal, something that's alarming to you. Maybe 4 of your community patients are having a certain illness. You might be the first one to identify something, and you need to be able to know who to call. So it's really important that you have these working relationships, that you're comfortable calling your local and state health department to be able to say, hey, I wonder, has anyone else been seeing this? Because I'm starting to see this problem. So that would be my first kind of takeaway. And then making sure whatever emails you should be on, you should make sure that you're always staying up to date with the email paths, because that can be a challenge too. Maybe you have some new team members, you want to make sure they're on the health commerce system, so you're getting alerts in not just you but other people within your organization as well.
Thanks, Melanie.
You're welcome.
Go to the next slide, please. So something to think about as we're talking about through the rest of the presentation today. Is your agency actively, that's the key word, working with your healthcare partners and your referral sources? So who are referring those patients to you, and that you're communicating their outcomes back to improve that communication and care coordination. So that starts with knowing who those partners and referral sources are beyond faxing one another. Also, an important component is knowing who the infection preventionists are within your agency, but also within the hospitals that you're working with. And also if they exist within the physician practices that you're working with. It's important that you be able to network with one another, that you know who one another are, and are able to communicate. One of the most top priorities to be able to make those connections. Looking at the next slide, please. So where to begin? So listen to what your patients are telling you, and actually open-ended questions. What are you hearing from them as far as their care management, the communication between the care settings? What populations are you serving, and that your agency understand the factors that contribute or impede to those target populations to achieve good health? What are some of the gaps in care that you're seeing? What are some of the challenges that we may not be aware of or think of as challenges, but the patients and caregivers are thinking of as challenges? Are you looking at your data? Are you looking at your infection prevention properties, policies, procedures? When an infection arises, are you looking at the documentation? How early was it identified? What was the response of the staff that were caring for that particular patient? Are there partnerships or alliances out in the community that should be explored and connected to? And how might your clinical teams within your organization work with those community partners to maintain those relationships, to maintain communication, and also connect with those local public health agencies that Melanie spoke about? Again, working as a team, providing that care and looking for those improved outcomes. So that's the first step. We move to the next slide. Some of the principles to focus in on for prevention and control. And Melanie, please jump in here at any point. I know you will want to. Patient and caregiver centered communication. You want to make sure, as you heard, if you participated in the last webinar, and we'll repeat it towards the end of this one, that the information you're sharing with patients and caregivers is clear and understandable and also respectful, and that they understand what they need to do once you leave that home. So we're going to talk about teach back. You're going to provide instructions to them. You're going to ask them to repeat that back, and we'll cover that a little bit later on, so that you know that they understand about services and supporting care and what they need to do at home. The timely information sharing, looking at infection risks, changes in condition, exposure concerns, prevention instructions. You want it communicated across that care continuum to all of the entities that are involved in the care management of that particular patient in a timely manner. Standardized processes for the staff to have, whether that be consistent forms or hardwired into your electronic health record, scripts or escalation pathways if they identify a change in condition or an outbreak within that patient's home. And also, what is the documentation? How and when is it done? And when is it communicated? What's the time frame? It should be before they're leaving the home. It should be communicated to all of the appropriate care partners and also to back to the agency. Interdisciplinary collaboration, talked about infection prevention being across all of the staff within the organizations, from the leadership down to the direct care workers, supervisors, the quality folks, educators, case managers, and administrative teams. This should be one of those agenda items that is in every one of your team meetings when you meet, about what you're seeing in infection prevention in the community and any outbreaks or opportunities to improve what's happening within the agency for the care management of those patients. And then also looking at those trends and patterns. How often are you seeing outbreaks or a change in condition related to infection? How early on is it identified? Is the patient, family, or caregiver communicating that to you? Have you instructed them to do that? And any update in any practices like a continuous improvement to make sure that your policy protocol is appropriate. Anything to add, Melanie?
Yeah, I did put in chat. I'm wondering who's on the call worked during the initial first couple of years of COVID-19, because I'm looking at this and I can see these are principles of infection prevention and control. We should be doing this all the time, right?
Right.
And just be thinking, what was unique about when an emergency is happening, when an event is happening? The communication was skewed, it was fast, people were getting a lot of misinformation. So we need to keep that in mind as we're growing our policies and procedures, that it needs to be direct and simple and quick, because wow, did the information come flying at us? And it would happen again. It would be the same set of circumstances if we were having another event, right? So I see somebody said I was part of all of COVID. Yeah. and you remember, and I wonder, I just to do something fun, what was the strangest, put it in chat, what was the strangest myth that you heard during that time that you needed to combat? So, I was working in long-term care at the time of COVID, and there was a lot of things coming my way that I was like, wow, okay. Didn't know that was the new rumor. So just be thinking, like, we need to be connected, involved, and being able, just found it, I find it interesting, some of the myths that were coming out. So,
and also, in the chat is a question about a template to use for infectious disease meetings. Have you seen anything through Epic or anything that you used, Melanie? I know when I was doing the research for this, I did see some online that we could research a little more.
I don't have anything at the top of my head, but I can chew on it a little bit and see what I can come up with.
Okay, great. Okay, we'll move on. Thank you. So the standard precautions we covered, again, Melanie covered this in across many of the programs that the 5 series webinars that we've done. The importance of the standard precautions for all patients, the hand hygiene, gloves for that body fluid contact, PPE as indicated, safe sharps handling, environmental cleanliness, and respiratory hygiene. And I just mentioned when we worked on Project First Line, what we found is that folks did receive, and this is in all of the settings we worked within, not just home care, they did understand and they did receive infection control training. But when we asked the next question, do you feel comfortable enough to explain it to someone else, albeit that could be the family? Do you feel comfortable? And the answers, surprisingly, were that there were some folks that did not feel comfortable. So making sure that they know the practical application and can demonstrate back. Right, Melanie?
Agreed. And that was really in before the event, we need to make sure these elements are hardwired, understood, and we're doing it well. Yeah. And that's why I thought, let's bring this back up, because we need confidence that our teams can do these elements well now before something happens.
Yes, absolutely. Next slide. Do you want to talk about transmission-based precautions?
Sure. And so, during the series, we've talked about transmission-based precautions. I did learn the last time I was on, curious to know from this group, how often do you have contact precautions in home care that you're asking your teams to wear the whole gear for contact, the gown and gloves. We're much more familiar, I think, with droplet, airborne, not likely to have too much airborne in the home care population, and then combined precautions when needed. So there are times where we need contact and droplet or contact and airborne, depending on what we're doing. But how often are you using contact precautions? And if it's a rare situation, ensuring that we're doing some training on how we're putting our gowns and gloves on together, and how we don and doff is going to be important, especially if we have if avian influenza becomes a problem in the future. We need to make sure we know how to protect ourselves.
Great. Next slide, please. Okay, one of the other best practices is doing an organizational assessment of your infection prevention and control processes. How often are you doing this? I am sure that post-COVID, during COVID, along the way, that this was happening many, many times, again, based upon what you were hearing were the best practices at that time to support prevent transmission. Looking at the current practices, taking time on a multidisciplinary level, not just leadership, involve your direct care staff, looking at the policies, the workflows, how does communication flow? What are you seeing from your meetings? What are some opportunities and gaps in communication? Those training records that staff have been educated in infection prevention, and also any incident reports or feedback. I would include that step, gaining feedback from the staff on any gaps prior to even sitting down to look at the policies and procedures. That would be ongoing if it was, I think that's important. Defining roles and responsibilities. The policies and procedure, do they clarify who leads the infection prevention activities? Who communicates with those external partners? Who monitors the follow-up? Who's looking at the overall communication and coordination of events for that patient? Standardizing tools like we were talking about before, and building them into your electronic health records so that it's not an additional step and that it's part of the process and everyone can view that information. So those handoff templates, screening forms, escalation pathways, your contact lists if something's identified internally, and also contacts within the community. And then educational materials that can be shared with staff should be standardized and, if possible, hardwire into that electronic health record so it's accessible at all times. Look at the education that staff are receiving for their competency training. Are there any updated steps to the process? Doing huddles and competency checks on an ad hoc basis. Looking at monitoring performance, and then also what's the data showing you? What are you hearing from your staff? Are you hearing any issues with communication, with their input, or the process that you've developed? So strongly recommend, if you haven't in a while, doing an organizational assessment on your policies and procedures for infection prevention and control. Next slide. Infection prevention communication pathways. So there are multiple versions of these that I've saw within our research for this. Staff, important to know that who are they supposed to contact to identify any symptoms? What are the exposure risks? Communicating any unsafe environmental conditions that they're seeing in the patient's home. Is there lack of supplies? And also, do they have questions about the precautions that are supposed to be used? Important that they have a resource that can answer those questions for them. The infection prevention communication pathways, it's recommended that they address: when is communication required? Who is designated to communicate infection prevention information? When and how is it shared? When should routine updates occur? What is considered urgent to require escalation? And also, what are the after hours and weekend procedures? Is it the same process? Do they have this available to them so they know how to follow that process and know all the steps that are required? Next slide. So some steps to take: designating an infection prevention lead or point of contact for the staff. If you don't have an infection preventionist within the agency, who is that designated person that knows where to find the information and knows the escalation procedures? Creating an escalation tree, that communication tree for suspected and confirmed communicable disease concerns. That standardization of scripts to be able to communicate with your care partners that are involved in care management of this patient, but also instructions to be giving to their patients and the families and caregivers. Ensuring that your supervisors reinforce communication expectations during onboarding, new hires, competency checks, and orientation and team meetings. And maintaining a process for notifying appropriate internal leaders within the organization on any infection prevention or trends or clusters or exposure events that are identified. Melanie, how did you do that did you have a lead within long-term care?
Yes, it's required to have an infection preventionist in long-term care. I'm curious if you all have somebody who's labeled as the IP in home care. And I also at one point, I worked at a hospital and we had some home care connected. And I, as the hospital IP, would go to my home care and do some audits with the staff, go into people's homes and audit. And really just because it's so unique. What you all do is so unique that just being able to see the process and say, well, this is how you might want to handle that. And this is how you might want to handle that. That's right. And then also, of course, that reporting structure of something's happening here. I'm a little concerned and we need to move this up and down. So, right, that communication up to leadership and then down to staff.
Great. And we're seeing in chat, our director of patient services and myself are the point people.
Fantastic.
Excellent. Important to know that the staff knows that as well, so that they know immediately who to go to. Next slide. So in emergencies, communication matters, and this is also one of those instructions that Melanie shared back in I don't know, webinar 2 or 3, using that plain language and emphasizing the why of each practice. Linking actions to their purpose in every explanation and limiting the amount of information that's provided all at once. And prioritizing the most essential points first. When you think about when we're talking with our patients, they're often thinking of something else. We also found from doing feedback, from asking for feedback, they often don't understand what it is we're explaining, but they're too embarrassed to tell us that that's the fact. So that is the value of teachback, to be able to identify that. Next slide. Do you want to talk about teachback now that I brought it up?
Sure. Yeah. So demonstration and teachback. And I think this is really important. Again, with the amount of information that we try as healthcare workers to get to our staff, to get to our our patients to move up to our county and local health departments, we are always in the process of communication. So hands-on teach back may just also be the information I just provided to you. Do you understand it? Is that making sense to you? So if we're going to try to teach somebody a skill, that hands-on learning is really important. So demonstrating the skill or the behavior. So behavior might be the way you put on a mask, or when and how you put on a mask. Invite them to practice the action, or it's explaining it back. So making sure they understand what you just said. One challenge we have is we have to make sure we're speaking in a language someone understands and at the level the person understands. So making sure we're not using medical jargon when we're talking to a patient or their family is really important. Creating a safe and non-judgmental atmosphere. Who's going to ask questions if they feel they're going to be judged? I don't want to do that. So we want to make sure we're putting people in a safe, let's talk about it, rather than, what you want that you're serious, that's a question. We want to just like, okay, well, let's talk a little bit more about that. I want to see how you feel about that. Encourage questions and praise success and effort. Use visual aids. So if you're concerned the information that you're providing is more than somebody can comprehend, and those short bulleted ideas, leave something behind. It's creating very direct, simple educational tools is very helpful. And then here are just a couple definitions. So Teach Back is an evidence-based health literacy intervention that promotes patient engagement, patient safety, adherence, and quality. The goal of Teach Back is to ensure that you've explained medical information clearly so that patients and their families understand. I'd also say staff, right? So we want to make sure our staff is understanding as well. So in Teach Back, you ask your patients or families and staff to explain in their own words what they need to do, or do they understand it? And it's more than repeating back what they heard, because people can parrot back what you said, but do they really understand the need to do this? Why is it important to clean your hands? Yeah, you told me I need to wash my hands before I touch my wounds. That's what you said. But do they understand why? So they're going to do it. So Teach Back is a strategy for you to validate that you've explained information clearly and that patients and family members clearly understand what you have told them. And this is a nice link to use for if you want some more information.
It's not, I just put a question into chat if folks were using Teach Back. Having to learn it is not as easy as you think. As a healthcare person, as a nurse, it's not as easy because we were so used to providing discharge instructions or providing education and assuming that they understand. But when you have to actually ask and they're looking at you like they have not a clue what you've told them, and explaining why it's important and why you're asking if they can explain it back, it requires a little practice. So role playing among staff is also a wonderful way to get more comfortable with it. Okay, moving on to another best practice, standardizing screening and risk identification. So when are patients being screened for a change in status, any signs and symptoms or risks for infection prevention? Is it being done before and during visits? It should be whenever there is a change in condition. And it's interesting to ask staff what their process is for this as well. Requesting clear instructions when patients return home. Do they understand if they were in a acute care hospital, critical access hospital, or a nursing home for rehab? What were your instructions? Asked to see them, see if they understand them, see if they make sense, and make sure that they have the supplies for those things. So once those patients return home, are there any transmission-based precautions that should be happening within that home for any wounds, Are there any devices or new medications, antibiotics that they're taking related to that? Looking at risk for signs and symptoms, also any recent exposures they may have, a new diagnosis that occurred since they came back onto service, any antibiotics, new wounds, pressure injuries, invasive devices that were implanted when they were in the hospital. And again, also those environmental concerns. And also looking at the caregiver capacity. Do they understand those instructions and are they able to carry those out? Prompting staff to report changes in condition, and I'm sure that your staff all do this already, but looking at fever, respiratory symptoms, GI illness, any draining wounds, or new isolation instructions that are required, and also infection-related documentation and identifying any trends across the agency. Pull those records and evaluate or look in the electronic health record system. What are you seeing as far as documentation? Are there any instances where infections become apparent or patients unfortunately are having to visit the emergency department or there's a change in status that wasn't picked up? What was the assessment that was just prior to that? Were there indications? Could it have been addressed earlier? And also ensuring that staff understand when they're supposed to contact the supervisors, providers, public health authorities, or emergency services, including physicians and other care partners. Next slide. Multidisciplinary and service line coordination of care. You have, being in the home care setting or community-based care setting, multiple disciplines, multiple care partners that are out there in the community providing health care to your patients. And it's important that they receive consistent information about infection risks and required precautions. One of the major goals in care transitions is making sure that everyone is communicating their assessments to one another so that the overall care management, everyone involved is aware of what's going on with the patient and what their risks are. So interdisciplinary case conferences for those high-risk, comorbid, high-risk infection, high-risk infection patients that you anticipate have the risk factors and are frail and elderly, which I'm sure is a lot of your patients. There are a lot of hospitals, home health agencies, nursing homes now that are doing weekly huddles on those high-risk patients, doing a quick discussion about how they're doing, are they managing well at home, and is there anything they need as far as services that will help them be able to stay at home and manage their care. Clarifying responsibilities for those caregivers and documenting what they're supposed to do and communicating also with the providers so that they know what you've done in the home. Sharing essential infection prevention information during handoffs. One of the things that we recommend is that you build into your intake form an area, if you don't have one already, that has specific questions related to history, recent history of infections, any risk factors that were identified. Do they have a history of sepsis? Because that is one of those areas that is repetitive and has a high 30-day readmission rate. And also common terminology so staff understand and can describe risks, precautions, and follow-up consistently across care settings. Anything to add there, Melanie, for communication?
No, you did a great job.
Oh, okay, moving on. Next slide. Okay, and then beyond the agencies. We talked about earlier building those relationships so that you have an escalation care plan, escalation plan, and so that staff, all levels of staff know what the process is before anything urgent arises within the agency with a patient. You want to make sure that the communication is fast and it's reliable if an outbreak or exposure is identified. Making an updated contact list for key providers, facilities, public health contacts that's easily acceptable to staff, not necessarily kept in the office, but something that they're able to use their EHR or their laptops or any devices to be able to look up that information without a huge delay. Melanie had mentioned before participating in infection prevention work groups. I would recommend that cross-setting communication and collaboration. There are emergency preparedness coalitions and exercises that are going on in the community that are important to be part of. And if you're not invited to be part of, I would reach out and ask to be invited to be part of those. And also connecting with those other infection preventionists. And then those communication templates for notifying those external partners that there is a suspected outbreak or a change in resident or a patient condition. Next slide. Okay. Incorporating infection prevention and transitions of care. Again, we mentioned about the standardized handoff report tool. So if you're using, some folks are using SBAR tools, situation, background, assessment, recommendations that nurses are filling out upon care transitions. There should be something that is utilized either in your EHR or if you're handing off to another nursing home or to the emergency department or hospital is handing off to you, that includes these factors that you see here in the bullet points. Their current infection status, what is the required precautions, what wounds or devices have they had implanted or removed during that stay with that provider, that history of sepsis, antimicrobial therapy that they might be on, any supply needs that are required to be able to care for them, what has been explained and what type of education has been provided, if anything, to the caregivers, and also any pending lab tests. They should not, whoever is assuming care for that patient should not have to try and figure out over an hour's worth of time why they're on a particular antibiotic and how long they're supposed to be on that antibiotic, and trying to figure out if anything has been done or what cultures showed. That should be part of that transition. Also clarifying if there is orders for pending labs or any cultures or provider recommendations, who is going to be responsible to make sure that they're followed up on and actually occur, and communicating any unresolved infection prevention questions to the supervisor at start of care, resumption of care. Also evaluating before you're going into the home what the history is, if this is a new patient that you're taking on, and any questions before you even arrive in the patient's home in the community. Next slide.
It's so important to take a look at antibiotics and question the timing. Often we find that somebody is discharged from the hospital with oral antibiotic for 7 days, but they've already taken 2 days of it. So they really are supposed to end in 5 days, but they end up with a script for 7 days. And that's how we get into that situation with C. diff, resistant organisms. It's really something we need to be working on throughout all care settings, the antibiotic use.
Absolutely. So our key takeaways. Patients and families must understand not just what to do, but why it matters. Plain language, focused teaching improves understanding and retention. Don't assume, ask those patients and use teach back. Make infection prevention part of daily routines, tie the practices to real life habits. Engaging the whole household in infection prevention, not just the patient. And also learning what happens across visits, monitoring progress and adjusting teaching. And empowering that patient and the caregivers and the whole household in being able to see what's happening, recognize a change in condition, and to report it to you. Next slide. Okay. We mentioned earlier, actually Peter mentioned the 5-part series of webinars that have been part of this program. So we summarized them here for you, and down at the bottom you can find the link where you can go and access them. And the wonderful thing is they build upon one another. So these are actual, I noticed in the chat that there were folks saying that they could use this information. We're looking for the slides, are interested in having the slides to do the infection prevention within the agency. And so these webinars will bring you through that, each of the different stages, the family and formal caregiver role, best practices for high-risk infections. So please take advantage of them. And I'll turn it back to Melanie to see if you have any closing comments.
I think my biggest thought right now is to just really focus in on, in the home care setting, being prepared for the unknown, using your really establishing those standard basic infection prevention and control initiatives, developing your protocols and your procedures and testing them. So that's always a really important thing. We write policies and procedures, but we need to follow that through into walking into the home and identifying, did the policy that I wrote and procedure I wrote actually make sense in this home setting, and doing it in a few different areas. So not just one home, do it in a couple different types of homes so that you can see that you've set your staff up for success. So identifying that basic, what is the basic common infection prevention? Have we provided good policies and procedures that function not in a pandemic, and would they work in the event of an emerging urgent situation?
Thanks, Melanie.
You're welcome.
And I just want to say thank you for the opportunity to be involved in this important initiative, to the Home Care Association and to Fidel for her guidance and support throughout the series. And we hope we found that information useful. Thank you.
Thank you very much. I'm sorry to mean to step on your words, Fidel.
It's okay. I was just saying thank you. Very grateful to you, Sarah, Melanie. Thank you for working with HCA. They do a great job, and together you complemented each other. So on behalf of us here at New York City Health Department and as the liaison to the long-term care sector, thank you, thank you, thank you. And to all those who attended and those who attended each session, thank you, because you can use this towards enhancing your comprehensive emergency plans, addressing those gaps in the sectors, and reach out, provide feedback as we continue this work. Thank you.
Thank you very much, Fidel. And I also put the link that that Sarah had shared and that Sarah and Mel had shared in that final slide into the chat, and we'll be sending materials out to all of our registered participants for the overall series of events that we have been fortunate to be able to provide around this critical topic. So thank you, everyone, and wishing you the best today. Thanks for joining us.